Hi, this is Chase Napier with the Healthcare Authority. Thanks for joining the webinar this afternoon. We're going to get started on some great topics of discussion. Again, my position is Community Transformation Manager. That's the ACH program under Healthcare Washington, so I'm the lead on the program. And in the room here, I have with me a member of my team, Lena Nashand. And so she's going to be participating and answering questions and just taking part in the dialogue. We're excited to have all of you with us today. You can use the chat function on the webinar to submit questions, and we're looking forward to getting through as many of those as we can. In addition, on the screen, we don't have a slide as far as a PowerPoint presentation, but we do have some information that we want to show as we go along today, including our Accountable Community of Health website and other related resources. So just keep that in mind if you want to learn more about our website and how to navigate that. It's going to be on the screen. And to support and kind of guide the discussion today, we have Jonathan Sive, a consultant to the Healthcare Washington team. And so I'm going to hand it over to Jonathan, who may cover anything that I missed, and otherwise I think he's going to just get the discussion kicked off.
Thanks, Chase. And a few more background points before we dive into a lot of questions, actually, that we have. A reminder to folks about the overall intent of the webinar. Or the webinars that we've been having, first to provide basic information about ACHs for those to whom they are still new. Second, to address in some detail the emerging issues or developments related to ACHs. To take questions from the audience to either answer during the webinar or at a later date. And finally, we see them as an opportunity for announcements regarding ACHs from either the Healthcare Authority or individual ACHs. The webinars both draw upon and help inform and update the ACH FAQ, which you'll find on the Healthcare Authority website, and other written documents which serve as key sources of information about ACHs. Today's agenda, we will focus in particular on the numerous ACH-related developments outside of the proposed Medicaid waiver, which have taken place since our last touch base webinar a few months ago. There's a lot to cover, so let's jump right in and hopefully be able to leave some time for questions at the end. So to Chase and to Lena, we're coming up on a key ACH milestone that will have the remaining ACHs joining the two pilots and moving from basic organization to specific activities intended to improve health within their region. Let's discuss these pending ACH SIM projects in more detail. First, can you just give a general sense for when we say HCA SIM projects, what does that refer to, and what's the significance of this upcoming milestone?
Yeah, so when we mention HCA SIM or ACH SIM work, it's because and just as a reminder, we have a contract with ACHs to support some of the SIM activities under our State Innovation Model grant. So we all along committed under our SIM grant to work with our ACHs on specific regional priorities and then specific regional projects to address those priority areas. So the milestone that you referenced is that at the end of July is our target date to have projects identified across the state, so one for each ACH. And the idea here isn't to limit the activities of the ACH. There's a lot of great work that's been going on, a lot of great work that will continue, but specifically we're looking at one project that we can attach some technical assistance towards, attach more evaluation support towards, and start to test this idea of multi-sector collective impact on a priority that the region has identified. So that's the milestone we're approaching. We might not hit that, by the end of July, that every region has a project identified, and we're okay with that. Some of it's about meeting schedules too and getting some final decisions wrapped up we're hoping in the next month or so to at least have most of them selected.
So let me correct a reference that I made because I think we get confused with these acronyms. It is actually ACH SIM projects. Because I want to be careful so people know if they hear this again what we're referring to. So with regard to these ACH SIM projects, what do you see as their purpose and why do they need to be done by the ACHs? What was the thinking that would have the ACHs now move to doing particular health improvement projects?
I'll chime in with my thoughts, but I'm interested in Lena's thoughts too. We know that, so a lot of Healthier Washington, we talk about how health is more than healthcare. Healthcare is a critical component, but it also extends beyond the delivery system into the community. So that's the type of partnership that's represented at the ACH level. And so the idea with the ACH project is to say, what kind of health issue can we focus on? What's a priority area that collectively the ACH partners want to work on? And then what can the ACH do that's different than one organization doing it by themselves or one sector doing it by themselves? So how can they come together? Not to say that every organization or every partner is going to contribute equally, but how can we take a different approach to identifying and then addressing a health issue? So again, it's something we're testing, and it'll be good to see what projects emerge and then how many partners are supporting and what the different kind of levers that exist in the community are to work on an issue. But it's all about trying a different approach across different organizations and also different communities, because we're hoping that some of these projects may span more than one community, more than one county even, and so it might just be a new partnership as far as the scope as well. But I'm interested in any other thoughts that Lena has.
I would also say, getting to the purpose of the project, ACHs have done a good job of getting together and starting to think about their organizational model. But I think it's also what are these ACHs going to do? And this is our first, I would say, toe in the water to ACHs doing something and trying out the governing structures they've set up and trying out the ways that they have gone about decision making and setting priorities. And now they're doing something about it and seeing if they are able to, if any corrections need to be made or any readjustments need to be made. This is a testing grant, and so we just want to have the ACHs kind of start trying some things.
So they really are moving formally moving from a development stage to a activity stage that I presume we hope to see characterized. I mean, this is sort of the launch of next chapter. But I also hear you saying that that as of all that's being done in Healthy Washington, it's a matter of, it's a dynamic process where we intend to learn from the implementation of these projects. To provide a little bit of context for a few other questions I have about the projects, I think I'm going to ask the question about some specific examples. So can you give the audience some specific examples of what we mean by project and what you heard in your work with the ACHs about the particular efforts they're going to be making in their regions to address and improve health status?
So with regards to projects and examples, we've talked about, and so I won't go there, with the Cascade Pacific National Life, we talked about their example of working with the school system and doing risk assessment regarding behavioral health needs. So that's one. We'll move on from there. So other themes that are coming up, and the project details are still being worked out, so we won't go into specifics around which region is doing which project because it's not all decided. But we're hearing a lot about working with community health workers or CHW-like models and the relationship to care coordination and engagement within the community. Also hearing about health and housing partnerships and really thinking about the relationship that exists between housing and health outcomes and access. And then also another one that I'll throw out there that I think is moving forward focuses on unintended pregnancies and some of the cost savings that you can see, but really thinking about how we can collectively work to address unintended pregnancies. And we'll be able to talk more to which regions are working on what projects and specifically what partners are engaged in all of that as we see those project submissions and have some more.
I want to take that last example because I think that allows to illustrate this notion of why the ACH or something, an ACH versus other entities that have been interested in the issue of unintended pregnancy. And I think I gather it is the notion that all of those around the table and others in the community, the idea would be what resources can each of them bring to the issue that the community has identified as one that they would like to address. So it's not simply a focus of one of the sectors, but the notion is how do they focus individually and collectively on addressing that, which really I gather is what it is you want to test with ACHs, which is how much more effective might they be in a community with an entity like an ACH to coordinate these activities rather than having them done separately and maybe even on different time frames, like by different organizations. So,
and I think one of the points that you brought up, or I feel like was implied in your point, was the projects aren't meant to be duplications of what's already happening in the region. My experience, there's a lot of really great work being done in the region, and it's what you were getting to of what collectively can these agencies and organizations that are around the table, if they think about what each of them are doing individually, can we be greater than the sum of our parts if we align and do it together?
Okay, so some sense for how, and I guess the right way to ask it is, how were these projects decided upon? How are they deciding on these projects? I understand there's some relationship between this process and the regional health needs inventories and the regional health improvement plans that are, it's sort of a data-driven approach to presumably data-driven and reflecting input from the voices in the community that are part of the ACH. But talk a little bit about how the projects are being decided upon in each of the regions.
Yeah, so thinking back to, you mentioned the regional health needs inventory, that's part of the early work that we set out on with our ACHs under the SIM grant and the sub-awards. And it was the idea that we should take a look at all the existing assessments that have been done because we're bringing counties together, we're bringing different sectors together in a way that maybe didn't happen, or maybe not on the same geographic boundaries or the same exact partners. So we wanted to think about an inventory of the assessments and some of the existing data, and then also an inventory of the work and what are the priorities and what are the focus areas within the strategic plans represented around the ACH partnership. So that's what we meant by inventory. So it wasn't conducting a new assessment, a new regional assessment, but pulling together those existing resources and assessments to do somewhat of a gap analysis, to have a conversation around what does the data say the needs are and what are we already doing. And so I do think that was a key contributor to selecting projects, but I think it also varies. I think the inventories were conducted in different ways in different regions, so it may or may not have been as instrumental in the basis for the project. I think another key factor is the interest of the partners around the room. So whether or not it's all based on the inventory and the data, it's also the recognition of the need from the experience of those who actually serve their populations and shared populations. And so I think that's a part of it that may not be directly tied to a specific assessment or inventory, although lots of it likely is. And then the other thing too is just what can we actually get data on and what's measurable, and we're looking at a specific timeline, so there are some logistics there too around measurement and the value proposition we're trying to establish within the SIM timeline.
So really it's both data-driven and, if you will, experience-driven, and both of them, and largely I gather that what these projects are was a decision of the ACH, not necessarily with a whole lot of requirement or direction from the state. There was significant flexibility for the ACH to make that determination as to what it wanted to pursue. Is that accurate?
Yeah, we put together an outline, I would say, and really though it just called for specific things like what's the ultimate outcome you're looking to achieve? How does that align with the Healthier Washington goals? What are the interim process measures and data sources? So really it was more about, we want to make sure that we have the data, that it is measurable, and also we do want to make sure that it is something that's different because of the ACH. What's the impact, what's the value add that exists because of the ACH that didn't exist otherwise? And that it's not just the value add of the ACH isn't just providing funding for a project that otherwise could move forward, but really how are we taking advantage of the partners around the table And again, that's not to say, we're not saying that every project is going to span the entire geographic region of the ACH with every partner contributing equally. But it's really having a conversation at least about that multi-sector approach to health improvement priorities.
How about how the project's being funded? Is it part of the base funding that's gone out to the ACHs? Was there additional funding depending on the project?
Both. So it's partially the existing funding because all of the work to date is with the base funding, which we'll just say was established under the sub-award, and it supported the regional planning, it supported the staff time for coordination, and supported the project selection. That being said, we have recently at least planned to provide $50,000, so it's going to be as projects are identified and confirmed. There is the opportunity for $50,000 to support the launch and the ramp up of the project activities.
Which comes from the SIM grant received from the...
Right, comes from the SIM grant in addition to the base funding. And so we just need to make it clear that ACHs don't yet have this funding, and it's really based on them identifying the project and getting that confirmed, and that would trigger the release of the $50,000, which would support the ramp-up activities. It could support specific project activities. It could support specific staff activities to coordinate the project. So a little bit of flexibility on how they use that, but that would be in addition to. But it's going to be an ongoing function of the SIM work as well. So there's going to be at least staff time that is paid for with the base funding. This $50,000 is, of course, limited in nature and also time limited.
So just one final question with regard to these projects. And we'll touch a little bit more on this notion of ongoing participation. But if there are those on the webinar or outside the webinar who are interested in learning more about particular projects, interested in becoming involved in particular projects, at this point, do you have anywhere that you would direct them, or will there be an opportunity to learn more as they become more developed?
So maybe we can just reference if you look at your screen, the website for the state ACH initiative, and then also on there, I believe we still have links to our ACH websites. And so I imagine they're going to be populating their ACH website. So this has their contact information you can see on the screen there. And if it's not on the other website, we'll make sure that the websites for ACHs are included on that contact sheet. So that's one way to do it. The other way is because we talked about the projects being tied to evaluation, so we have an evaluation partner, Center for Community Health and Evaluation. They're going to be doing pretty rapid formative evaluation and reporting back to us. And so not all of that information might get populated on the website, but I think that we can do a good job in more frequent patterns of pulling out that project-related progress and making that available. So it may be that we take specific pieces of those evaluations and learnings and include that. So again, I think through the ACHs directly and the websites, and they're going to be, I think, increasing the use of websites and making information more available, and then we'll do a better job of, I think, trying to create a snapshot of the project activity.
Okay. Let's move on to some other things that ACHs have and will continue to be involved in. So several weeks ago, the Healthcare Authority released its value-based roadmap, which has the ACHs playing a significant role in the state payment reform efforts. Can you talk about this? What ACHs are doing now to prepare for this? And then in particular, does this only come into play if the Medicaid waiver is approved, or is there a role for the ACHs? And does this roadmap make sense even outside the context of receipt of the Medicaid waiver?
Yeah, and you can see on the screen here, we've pulled up the value-based payment roadmap that you're referring to, so the VBP roadmap. And just full disclosure here, we're going to come at this from an ACH initiative perspective with the caveat that we're not the VBP experts. But regarding the role of the ACH, first, it exists outside of the discussion around the Medicaid transformation waiver. There are pieces of this that refer specifically to components of the design of the Medicaid transformation waiver and funding that would be time limited as part of the Medicaid transformation waiver. But the concept it really applies outside of the Medicaid transformation waiver as well. And for the ACHs, so essentially, if we're trying to move from a system that is more fee-for-service and service-driven to one that really is more outcomes-driven, which is where we get value. We're talking about health outcomes and quality. Then it really does lend itself to an ACH-like approach, where we're talking about all of the things that impact quality, all of the things that impact health, beyond a specific financing structure that pays for services or not. And so if we're going to go to a world of thinking about health, regardless of what contributes to health and the different types of activities in the delivery system, but also outside of the delivery system, that type of partnership and that type of collaboration that we need to see happening, and the coordination of services around a person and their experience and their health, that's the type of partnership that's represented around an ACH. So you can see for sure a role in that type of community collaboration that's talking about the health of their population, regardless of where and how, but all of the things that impact their health. So the idea of value-based purchasing was a discussion before we were talking about the Medicaid Transformation Waiver. The role of the ACH in this type of transformation was also on the table before we were talking about the Medicaid Transformation Waiver. So clearly some things we need to pay attention to and some particular pieces about the waiver, but the idea of collaboration and going to the community and thinking about community needs and thinking about strategies to work differently, that's what the ACH is all about, and that's all about the value system.
So it's that notion that either the state with its programs or the commercial carriers for employers, with the state, in this case the state as the lead, paying for outcomes, paying for improved health in communities, and a recognition that to get there goes beyond the clinical walls to include the other services and organizations that are likely, that are and will continue to be represented at the ACHs. So the role of that ACH is to bring those partners to the table, and they ask themselves, how can we assist, complement, supplement the traditional, if you will, healthcare delivery system in order to deliver the outcomes in terms of improved health that the state and others who pay for it will be looking for. Does that capture it, Lena?
Yeah.
Okay.
In a nutshell, I think there are a lot of nuances to this work that are pretty challenging, and I would also say there's a lot of different ways that we think about and look at value-based purchasing. If you look at your screen, sorry for the speeding up for those of you on the line, you know, we've set this as our standard VBP categories. So those are different payment models, and there's different ways of approaching this work. So there's a lot of nuances, but I think in a overall nutshell, I think that's correct. And how do we move from purchasing kind of volume to value, and what does it mean to think about purchasing health outcomes rather than incidents of care?
Great, thank you. So the roadmap also talks about incentive payments, and you can see on the screen reference to incentive payments tied to a subset of measures from the state's common measure set. And the Healthcare Authority recently announced 7 measures, including those regarding well child visits and diabetes care, that would be this initial set to which this initial set of incentive payments would be tied. What's the significance of identifying well child visits and diabetes care as the measurements that would initially be focused on?
Yeah, so you mentioned the 7, so it's just starting there, that going from the description of incentive payments to, okay, what are the actual measures that are related to those incentive payments. So that's where the 7 measures came into play. And 2 of those you've identified, well child visits and diabetes care. And this, for Healthier Washington, and there's some communication that that will follow up. Maybe we'll add it to the next, we'll keep this as a topic, maybe add it to the next conversation or make sure this communication goes out. Regarding Healthier Washington wanting to support these 7 measures, but specifically thinking about well-child visits and diabetes. And I think the focus within diabetes is blood pressure and A1C. So the significance here is now we're actually starting to define what value looks like, because we have to get down to, okay, what specific measures are we going to look at? How are we going to evaluate whether or not we're making progress? And so as managed care organizations are being incentivized to work on these 7 related measures and the care and outcomes attached to those measures, these are 2 examples that Healthier Washington is going to start putting some more specific energy and synergy around, and thinking about all of our different investments and all of our different component parts, and how do we work together to support these focus areas, knowing that also our managed care system being incentivized is one of those component parts, and it's one of those levers. And so thinking about how all of our pieces move together, including practice transformation, including our accountable communities of health, including the plan for improving population health, we have a workforce development component. So all of these pieces working together on specific focus areas, and these are the 2 that we're starting to have conversations around. Okay, what does this mean? We're going to work together, and we're going to think about these incentives and how we, as a system, can move together.
So I think what I'm hearing is that, again, an example of where the ACHs are part of overall Healthier Washington. And though it sounds like there is more to come on this, that the well-child visits and the diabetes care will be a theme we see repeated in other parts of Healthier Washington at this point, moving forward, or at least initially as a focus area. And the fact that they are what the initial incentive payments would be tied to, again, it's something we will see reflected in other parts of the work of Healthier Washington.
Well, in those 7 measures that we're referring to, they're in Apple Health contracts before now. There's been a 1% withhold based on the quality of data that's been submitted. So it hasn't been about outcomes necessarily, but it's been about submitting the data. Now there's going to be a 1% withhold in Apple Health contracts that is tied to outcomes. So it's taking something that existed, and instead of saying this 1% withhold is based on just submitting some information, it's about what information you're submitting and if you're moving towards a quality outcome. Does that help?
No, that
helps. And just one other thing, just thinking back to, okay, well, what's the connection to the ACHs? Again, our managed care partners are within each of our ACH regions, and they're participating, in meetings that I go to. They're actively engaged in the regional priority and planning discussions and work groups around specific projects or activities. Mm-hmm. This is going to start to be part of the conversation as well around how now the managed care organizations and the system is moving and looking at these specific incentive measures, and so how does that reinforce the partnership that exists? And it puts a little bit of definition around some of the activities they could work on, and I think brings them to life, and it gives you a little bit more clarity around, okay, we look at well-child visits and specific diabetes-related measures. That now can shape the conversation around, okay, what does the population within our region deal with, and how are we doing, and what can we do, or the specific targeted activities we can do together that maybe we weren't thinking about before. So I think that's where the ACH role can come into play too, because they're already thinking about related issues, related activities, and now maybe there's a little bit of definition and a little bit of momentum behind some focus areas.
So another of the areas that the ACHs, Healthier Washington areas that the ACHs were to be involved in is practice transformation. And perhaps we won't spend as much time on this, but if you could give us just a brief update, not necessarily on the practice transformation component, but to the extent there is some information provided that is relevant to the ACHs and the roles they will play with regard to practice transformation and how that part of this project is developing.
Yeah, we'll have to just be really brief here and speak to what we know, and the information may be evolving as we continue to quickly move things forward. But there are some contract negotiations going around with the apparently successful bidder for the practice transformation work, and some more to come on that and the specific design of that work. What we do know, though, is that the ACHs will be a partner with our practice transformation initiative, so we may see specific coordination that happens within the regions. There may be actual practice transformation connectors of sorts that exist or that move into the specific regions or that are provided as a resource to providers within the regions and would work with the ACHs. And I think what we'll have to think more about is clinical community linkages, and that we've called out for the practice transformation effort. And clearly the ACH does also represent partnership that spans the clinic and the community. And so I think there's going to be a partnership that exists with those connectors. So we don't know yet the exact design of that model, of how that placement would take place, what the emphasis might be on provider interactions and provider coaching as opposed to actually being plugged into the ACH. But I think that there's a bridging opportunity there. There's kind of that connecting opportunity that we could see. I think ACHs have done a great job, but that being said, I think we could do more on interacting with providers and really connecting the provider community to the work of the ACHs. And so I think that there's opportunity there, and we'll see more specifics as the contract's finalized and designs move forward.
So if nothing else, what I'm hearing is that in addition to the particular SIM projects that will be emerging from each of the ACHs, continued engagement with regard to the state's efforts on value-based purchasing. The ACHs the plans are for that they will continue to be part of the practice transformation development as that happens. Let's talk about some particular documents that were recently released, or particular information, I guess. Starting with a document that came out late last week that I believe is available on the website, that is labeled the SIM Contractual Guidelines for ACHs. Can you talk a little bit about this document, what its purpose is, how it was, give a little context so that those either who haven't seen it can decide if it's something that they would find of value, or for those who have seen it, have a sense for why it's out there and what purpose it is supposed to play.
Yeah, the ACH subawards and contracts have 3 categories of work. We've talked about these categories, just not by name, but they have really the governance and development function of building the governance and staffing the ACH as a partnership. And then they also have the regional health improvement planning category, and then they have the actual transformation and activity that's going to occur. So those 3 broad categories, and we had some level of detail in there, but again, all of this is a test and all of this is evolving. The ACHs are new, and so we've really treated this all along from the beginning as a partnership, and as we learn together and we adjust together with our communities. So this document is really, it reflects a lot of the conversations we've had with ACHs, a lot of the guidance that has been provided, but I'd really say it's more so the learnings that we've had together and how we start to add some specificity to the contract categories that were pretty broad. So this tries to break it down in a little bit more detail. The target audience then is our ACH leads, really our organizations that are staffing and that are coordinating. They're the ones that are accountable to the contract. We're talking to them on a weekly basis, if not more frequently. Others are welcome. We posted it online and welcome to see this and see the type of work that ACHs are moving forward on and some of the guidelines. But really, this is not everything that the ACH is. This is thinking specifically those categories of work in our contract that we actually do oversee, and what are some of the definitions around that work? What are some of the minimum expectations related to governance, related to regional planning, related to the project? So us mapping out our expectations for our sub-awardees. There are a lot of other activities and a lot of other functions that the ACH can take on and does in most regions. And this doesn't outline all of the ACH work, and that's why we were very clear on these are the SIM contractual guidelines, saying that as we've learned and as we've kind of developed together, we're going to start to put some pen to paper on a lot of those learnings and the direction that we've found ourselves in with our ACH work.
So also recently launched was an ACH Toolkit website. Can you talk a little bit about what this is about, and how might those on the webinar otherwise want to make use of this? How do they access it?
ACHTA.org, so we're pulling it up on the website. And just a caveat here, this is still in development, and so you won't find material in every section, at least not fully developed material. But we have a contract with a technical assistance provider provided by Empire Health Foundation on behalf of the Health Philanthropy Partners, and they have really been instrumental in supporting our ACHs. We do a variety of things, and this is one resource among other activities. And this is going to be a compilation of existing or newly developed resources related to these categories. You can see plan, lead, govern, operate, transform, sustain. So broad categories of different types of technical assistance materials, different types of webinars, different best practices that are identified nationally. And so this is a way to just house it all in one location for our ACHs, and again, very specific to the ACH context, trying to be targeted, trying to be responsive to ACHs. A lot of this is going to be rolled out either through quarterly convenings or through specific webinars or specific technical assistants and subject matter experts that we bring in. But this is somewhere that we can then start to house that information and have it be available for ongoing reference, and not just have things be a point in time, but start to pull from other resources and also populate it with our own resources that are emerging through technical assistance.
So I assume you anticipate that the ACH, individual ACHs will contribute to this as well, and this will be if you will, a clearinghouse for information that the individual ACHs may develop to share with other ACHs and others around the state. So if they can identify common issues and common questions, it will be a good place to go to see if other ACHs have wrestled with that same question or concern and what answers that they've come up with. So it's not simply information that the state or its TA provider will provide, but it will draw from the ACHs to help populate this website as well.
Yes. So as you can see, it's still being developed, but there are different documents on here, so that could be of interest. So different documents, and then one of the things too is that each ACH last year under our TA had the opportunity to kind of get specific tailored TA, and so the work that was done out of that will be included here. So under these different headings, eventually there will be kind of the thing. So you can see here, King County ACH Principles to Sound Governance. They worked with a lawyer named Keith Nagayami who did a presentation for them, and this is his presentation. So you can kind of click on these different things and see, okay, here's the presentation that was given to the King County Accountable Community of Health, and kind of what it contains. So this is just Change Lab Solutions is his, and you can see what he did for King County, and it's there for all ACHs, and so all ACHs can see this as a resource. So.
And so if folks have ideas as to what they would find useful, can they get those to you? Is there someone else?
For the TA Toolkit?
Right.
Yeah, they're welcome to contact us, and we're happy to talk about different ideas. It is designed to be technical assistance for the ACHs, and in that the technical assistance engages with our ACHs on a regular basis. But we're also open to other ideas and want to hear from people about what they think would be useful for ACHs.
So we've got a few more questions here, and then we will go to, we've got a number of questions from the audience, but I think the remaining ones we have here are fairly quick. And maybe this is just to emphasize as much a statement as a question, but the question is, what opportunities remain to become involved with ACHs? And I assume that the opportunity remains for those who are not yet involved to become involved. And so if I'm an interested person or organization, what do I do if I want to become involved with either ACHs statewide or ACHs within my region?
Yeah, we have the contact information, because you're right, it's not too late to get involved, and I think we've mentioned this before, that involvement can look a variety of different ways, and the best way to find out what the opportunities are is to contact these leads for the different ACHs. In addition, most ACHs do have websites. They're all developing websites if they don't yet have one, and that's where a lot of really important information is posted to around specific meetings and notes and meeting minutes, but also a schedule for upcoming events that are open to the public to join. So ACH websites would be another way to get that. And I think what we will do going forward is maybe try to update that contact info so you can both contact the person and get the website in the same location. So those would be two really good ways. And then, staying engaged in these types of calls, we can then provide updates as we understand them. But for community-specific opportunities, we're really going to have to reach out to our ACHs, and that's going to be the best way to.
And my understanding, too, particularly as the ACHs move to implement their SIM projects, that there really is a need for folks within the region and within particular communities to engage on the particular projects, and not simply, if you will, at the governing level, but to really be part of the ground level work that's being done by the ACHs, and more will come as the opportunity will be evident as these projects begin to get more focused and concrete. But it sounds to me like there's still ample opportunity for that to happen as well.
Yeah.
And need.
Yeah.
Okay.
There's a lot of expertise around our state in all the different regions, and the idea behind an ACH is that they're tapping on their local expertise and their local experts to work all together. So that most definitely is a need.
So I want to talk about some particular engagement, because I know it's something that the Healthcare Authority has put some thought and effort into, certainly recently. In addition to promoting cross-sector representation engagement generally within ACHs, you're working with the ACHs to assure in particular that tribal governments are appropriately consulted and involved. Can you talk some about this and recent efforts in this regard?
Yeah, it's something that we were working on from the beginning, but just recently have been able to work more closely with the American Indian Health Commission of Washington to provide a little bit more direct support. So at the beginning of this year, we actually reached an agreement with them to provide some direct support to the state, to ACHs, and to tribes and urban Indian health organizations within those regions. So the whole idea was to recognize that tribes are, as you said, government entities and independent government entities, and we need to develop appropriate strategies to bring them into the conversation and to bring the conversation to tribes. And it may not be the same in every ACH. That yes, we maintain the government-to-government relationship and consultation. In addition to that, though, as the community coalitions are up and running and maturing, how can tribes be informed and be involved as a partner? And so that's been the conversation. The AIC partnership is really around educating ACHs regarding tribal engagement opportunities, also bringing Healthcare Washington and the concept of the ACH to tribes. So doing some shared learning among the tribes and the ACHs, and then to work on specific strategies. So then where do we go from there once we have a better understanding? Then what does that partnership look like? Is it a specific engagement in the ACH? Is there a statewide engagement opportunity? Does it look different in every ACH? So there's not a preconceived idea of what that engagement looks like, but that's one of the outcomes, is to better understand what each tribe might want to see with their particular ACH.
So let's move, we've got just a little over 10 minutes left. Let's move to some of the questions that we've received from the webinar participants. And I'm going to combine one of them, and I think I've captured it. Or hopefully I've captured the general sense of the question. And it starts off with the notion of community health workers. And I will read the question, and then I think try and summarize what it's getting at. It says, community health worker network coordination requires technology. Is there a, quote, table for this discussion so that ACHs could choose to the same or compatible software? A related one, isn't a robust regional community health worker network a major key to the puzzle of practice transformation, shared infrastructure rather than lots of one-offs? So I'm going to ask the question this way and use this as an example, which is that the ongoing challenge with ACHs as to what is a, if you will, one-off regionally versus those things that develop maybe at a regional level, but where we are a state and where we see uniformity and we want to see uniformity around the state. This example, a good one, where the notion of network coordination that is based on a statewide technology, not a technology that's unique to each of the 9 regions. So can you talk a little bit about, perhaps using this example, what the state is learning in terms of decisions that are made at the ACH level versus decisions that will need to be made at the state level in search for statewide uniformity for some of these things. Again, that's a perfect example where what we would not want to have is 9 regions with software that couldn't talk to each other when the interests and needs cross those regional boundaries. So,
yeah, so I know ACHs are also really interested in this idea of talking across regions and working across regions. It has come up as we think about potential Medicaid transformation projects, but it exists now. And even this morning we were starting to talk about the different interests that ACHs have in community health worker activities and projects, whatever you want to frame it as, and starting to think about some type of central mechanism to have this discussion around CHW models, and so I think it gets to that point that they have the same desire to work across regions with one another and also with the support of the state. I think that's the other thing too, is this is a really different type of partnership with our communities, and so engaging with our practice transformation leads as that develops. I can't speak for the specific pieces of support that may or may not exist there, but that's the exact kind of conversation as we see, okay, clearly there's community momentum and interest here. Doesn't need to be designed 9 different ways, and maybe it isn't even feasible to design it 9 different ways. And so how do we coordinate across regions, and then also pull on practice transformation as a resource, and pull from our ACH technical assistance team as a resource to identify other promising practices. And so I do think that that's exactly where we need to go.
And I presume too that the notion of the state being the significant purchaser that it is, that it does see itself rather than a regulatory role, but that as a purchaser, it can, if you will, drive some uniformity statewide, saying, there are certain things not only are we comfortable being done at a regional level, but we want to be done at a regional level, but there are other things that we believe the state would be best served if done on a statewide level, and that there will be this ongoing process of deciding which of those fit into which category, and then again, using the states as a purchaser to say this is what we expect from our healthcare delivery system, and part of that very well may be more coordination across regions where it's deemed appropriate, or again, necessary to achieve this triple aim that we talked about. Another question that came in, a more general one, and maybe I will, for time purposes, be more specific. So the question is, do you have a sense of the challenges that the ACHs are having at this stage? And maybe what I would say is, can you identify for you the top 1 or 2 things that you're hearing in terms of, 1, 2, 3 things that you're hearing in terms of current challenges that the ACHs are facing?
I'll provide one, and I'm sure Lena will provide one as well. So authentic community engagement is something we've talked about, and I don't think it's going to go away. It's going to continue to be a priority, and it's both a challenge, but it's also that it's one of the greatest opportunities, I think, that keeps it at the forefront. But it's figuring out what does that mean? What do we mean by authentic community engagement with a diverse representation that the ACH represents the entire population? I mean, that's really what we're talking about here. So within a geographic region, the entire population. So if you're going to go to a model that does authentically engage the community, there's a lot you could talk about, a lot you could do, and so to focus on where do we start and how do we support that, and is it different in different communities, and is it different in different regions? And so I think that we haven't solved that equation around how to authentically engage community members, and how do you define that engagement, and also how do you reach the entire population, because we're not talking about just the Medicaid population, we're not talking about just those represented by the organizations around the table, but we're talking about all of those individuals within the community. So that's, I think, going to be a priority, a challenge, and really important for us to figure out going forward. And then Lena might have another.
What would you say a top challenge that they're confronting right now, or challenges, if there's a few that come to mind?
I would say a challenge I see that across the state, I travel across the state and go to multiple ACHs, and I think one of the challenges I see is that we're trying to change things. The idea behind what we're doing is to have a different way of delivering and paying for health care and have better health outcomes, and we're trying to change that. And how do you conceptualize something that has been done in maybe tiny pockets or at single clinics, but do it on a really systems-wide level? And what does that mean, and how does that work, and what will it look like? And somebody in an ACH said, it hit me. I don't know what it's going to look like, but it's going to look different. And that idea of we get to decide together what it's going to look like and have discussions regarding how the system should work, but coupling these kind of large philosophical questions with a rapid timeline and needing to move to action. We don't get to sit around and philosophize about what we're doing. It's time to start doing some things, and that operationalization of it is really challenging.
And I want to follow up with another question from the audience, but very quickly, want to mention, because I want to make sure we listen before we go, we have talked a lot about the things being done by ACHs without much mention of the proposed Medicaid waiver. So I at least wanted to mention, and you can fill in the details if you have them. I believe that there will be the next update on the waiver is August 4th. Mm-hmm. So there is an update webinar specific to the waiver that will be held on August 4th for those who are looking for a deeper dive and more current information on what's going on with the waiver. So for those of you interested, in addition to these other activities what's going on with the waiver, we want to make sure and reference the August 4th webinar that will provide much more detail on that. So another question from the audience. I think it gets to the variable challenge. I think, Lena, it might be something that you were at least indirectly addressing. And the question is, who owns population outcome? This idea of you know, the contribution to well-being of the medical system is relatively small, and yet it's where we tend to focus most of our attention. How do we create the environment? How to create the table that the medical system parts and the payers participate for population health? And I guess I would say that sense that is among the purposes of the ACH. Your sense for their success in moving that direction, and what are we learning about this idea that that we need a system, and the payers, the state is fair. It is looking to incentivize a system that looks beyond simply what happens in clinical settings. How do we build that into the system, and how's it going so far, I guess?
So I guess I would approach it from because I think we understand that ACH represents the population. We understand we're interested in health outcomes and population health. But when we're talking about payers and the delivery system, I go back to our shift, and it's going to take time, this idea of moving towards a value-based system and defining that and incentivizing that. We haven't talked much about this today, but the common measure set, is defined a certain way, and there are certain measures. But what is happening is, even if you take those specific measures, and you can take the example we had earlier of well-child visits, or some of the diabetes measures we mentioned, you can think about how the partners across the region still have an impact on those specific outcomes. And so I think that's one way that it's happening now, is that at least in the meetings I'm at with ACHs, and I think the same is true for Lena, starting to think about, even if we define it a certain way and it's limited to certain measures at this current point in time, and this is the status of our value-based framework, you can still start to work out from there and work backwards to, okay, what are the specific strategies that do influence and specific partners and services and factors within the community that influence those outcomes, such as well-child visits or diabetes. So I think that it's starting to happen, even if we have pockets and we're working with specific definitions, you can still start to have that conversation. And I think it continues on beyond that one measure.
So I think we've reached our time for today. Thank you to Lena and to Chase and to all of those participating, particularly those who submitted questions. We were able to get to many of them. I know we didn't get to all of them, but we'll make effort to follow up as appropriate there. As always, continue to stay engaged on the website to look for ongoing updates and information. And I guess I would just close by asking Lena or Chase anything else you'd like to add before we close.
No, just thanks Jonathan, for navigating the discussion, and thanks for all of the questions, and we'll talk to all of you next time.
If you have questions, please let us know. We're happy to talk about this.
Thank you much.
Thank you.